Good morning. Good morning. I'm Andrea, and we're going to get started in just, I would say, like a minute and a half. We want to allow some folks to join in, settle in, grab some water. I'm excited because we're in for a treat today. So we'll just get started in about a minute. I'm seeing some comments of folks excited to learn from Imani today. So thank you all for being here. Okay, well, it's 10:02, which for me means that it's almost 10 o'clock. So I'm going to get us started. My name is Andrea Perez Maicola. I use she, her pronouns, or ella in Spanish. And I'm the program manager for diversity, equity, and inclusion at the School of Public Health here at the University of Minnesota. So before we begin, I want to acknowledge that the School of Public Health at the University of Minnesota Twin Cities is built within the traditional homelands of the Dakota people. Minnesota comes from the Dakota name for this region, Minnesota Makoche, which loosely translates to the land where the waters reflect the skies. It is important to acknowledge the peoples on whose land we live, learn, and work as we seek to improve and strengthen our relations with our tribal nations. We also acknowledge that words are not enough. We must ensure that our institution provides support, resources, and programs that increase access to all aspects of higher education for our American Indian students, staff, faculty, and community members. I also want to point out that closed captioning is available. You can access that by using the icon in the bottom right corner of your screen. You can also reach out to Sarah Harris, who is providing our tech support for today via the chat to ask questions about accessibility. We will monitor the chat for questions as well as share links to our evaluation and information about future justice and public health events. The Justice and Public Health series was started last year as part of the School of Public Health's commitment to justice and anti-racism. We have been hosting monthly events with local and national experts around topics of public health. The speakers and presentations in the series help to ground us in theory and in practice, as well as complement the classroom learning that our students experience. We also hope that today's discussion is part of a broader change happening outside of the School of Public Health. So if you're interested in staying abreast of other justice and public health events, please be sure to fill out our event evaluation after this and check the box to receive notifications about upcoming events. You may also visit our website at any time. This event will be recorded and will be available to view on our website for about 180 days, plus or minus. So now I want to welcome our speaker for today. In a world built on ableism and set up for a very specific type of person to thrive and win, what does work look like when brands and individuals make space for the entire human experience? Imani Barbarin explores the realities of navigating work while living with a chronic illness and/or a disability, how to advocate for yourself while achieving your work goals, and how companies or universities can create a work environment that supports everybody. Imani Barbarin is a disability rights and inclusion activist and speaker who uses her voice and social media platforms to create conversations engaging the disability community. Born with cerebral palsy, Imani often writes and uses her platform to speak from the perspective of a disabled Black woman. In the last few years, she has created over a dozen trending hashtags that allow disabled folk the opportunity to have their perspectives heard while forcing the world to take notice. Hashtag patients are not faking, hashtag things disabled people know, hashtag ableists are weird, and others each provide a window into disabled life while forming community. Imani is from the Philadelphia area and holds a master's in global communications from the American University of Paris. Her published works include those in Forbes, Rewire, Healthline, BitchMedia, and more. She runs the blog crutchesandspice.com and a podcast of the same name. I would like to welcome Imani Barbarin and my awesome coworker, Lauren Jones, who will be moderating this conversation for you all. So thank you both awesome Black women for being here today.
Thank you.
Thank you, Andrea. Imani, how are you feeling today?
I'm good. I'm a little achy because it's a little humid and rainy outside, but I'm good otherwise.
Good. And where are you located at the moment?
I'm located outside of the Philadelphia area on unceded Lenape land. And yeah, I'm just around in the suburbs.
Okay. So I'm coming to you all from North Minneapolis, where it is snowing outside, and I'm also dealing with whatever is going on in my body. And so if I blow my nose or whatever, excuse me. Again, my name is Lauren Jones. I use she, her pronouns. I'm the director of DEI here at the School of Public Health. In terms of the conversation that we're having today, we've already created some questions, and so we'll go back and forth with that. If you have questions, you can, of course, put them in the chat. And then I'm coming from a space of dealing with my own illness and chronic pain. So I've been diagnosed with endometriosis, which is a painful tissue, overgrowth of tissue, essentially, in my body, as well as some other things. And then my partner has kidney failure, and so he's also dealing with dialysis, which we were talking about before. So we're going to jump right into the questions, unless you had something else you wanted to recognize or say.
No, thank you. We can get started.
Cool. So here in Minnesota, after Prince died, the state altered the way that pain medication is administered. For example, regular physicians, so just your GP or whoever you go to, they're very limited in how much pain medication they can prescribe. So people have to go to a pain clinic if they want more support. So I have to go to these myself. So I personally have found the experience of trying to get medication to be incredibly dehumanizing and humiliating at times. As a Black woman in pain, I'm concerned about being believed about my pain or the extent of my pain. And the medical cannabis program, which we do have here, is cost prohibitive, among other barriers. What are your thoughts on the way pain is managed in this country? Or do you have broader thoughts about how we manage prescriptions in general?
I think when it comes to pain management, there is this idea there, we try to prescribe a one-size-fits-all mentality towards both addiction and pain management. And we have a history of criminalizing, particularly Black and Brown people, for seeking pain management. There are so many anecdotal pieces where Black women in particular have gone to the doctors and gotten major surgery, and then were given a Tylenol to go home on. And then if you asked for anything stronger, you were seen as drug seeking, you were seen as belligerent in some cases. Sometimes the police gets called on you and you're in your hospital room recovering from a very major procedure or something that was incredibly painful. And I think we have to recognize that that is very much so in people's minds when we think of, for instance, the opioid epidemic or drug use in general. And we don't really do a good job with nuance when it comes to pain management. We think that there really is, I first want to say that addiction is real. Addiction is real, because I think that we go one way or the other and say, not everybody on painkillers is addicted, and then, or everybody on painkillers is drug seeking. It's just, there's a lot more nuance to the issue that the system itself is not designed to address. And when we go through pain management, there has to be a recognition of the way the criminal justice system has been abused to harm people in pain, and to further criminalize people who are in very vulnerable positions. And there are no easy answers. There's no easy answers on how we address this, but I think making sure that policymakers realize exactly how the system has been weaponized, but also trying to care for people who are in active addiction at the same time. And yeah, it's very difficult and it's very expensive. For a lot of disabled people, they're being told, well, go to this pain clinic and we're going to teach you how to do yoga or stretching. And they're like, I go to physical therapy anyways. What is this going to do for, my complex regional pain syndrome, or, my pain associated with sickle cell or things like that. And it's very devastating, and people are dying. People are literally dying from the lack of access to pain medication. So as much as we want to criminalize and paint it with a very broad brush, we have to be extremely careful about how we talk to individuals about their pain.
Yeah, thank you for that.
Yeah.
I know I was prescribed like vitamin D for pain at one point. Yeah, he was like, well, you're not getting enough of your vitamins. So here's B and D, because y'all don't get enough sunlight, apparently. So that was the thing that happened at the pain clinic.
And I just want to add for a second, I think when a lot of these celebrity deaths happen around pain medication, what really baffles me is that the system will then create all of these restrictions in terms of getting pain medication, when in reality, there are a lot of privileged people with wealth, connections, and access who will get those medications anyways. And the people who will suffer are the people who can't afford that medication in the first place, but are still overexerting themselves to get it. You see what I mean?
Yeah.
So there's like this weird reaction where they want to do the restricting and the policy making on the back end, but without realizing just who's privileged and who has access to getting those things more easily, and realizing those restrictions don't even really apply to the very people that were harmed initially.
Exactly.
Yeah.
100% agree. So I was going to ask a question about making space for your Blackness, but there's a really good and related question in the chat. And so I'll ask that one first. So I would be interested, Emily Edson asks, I would be interested in knowing if Imani has any advice or tools for those who want to advocate for access to pain meds, especially for Black and Brown people.
What I would do would be to connect with a patient advocate or pain advocate in my area. I believe there's a National Association for Pain, people with pain diagnoses, something along those lines. I really can't think of it. It's off the top of my tongue right now. But they have advocates that will work with people to make sure that they are getting the access that they need. My main advice for anybody who is struggling advocating for themselves is partner up. Partner up with somebody who is trained in advocacy, somebody who knows the system well and can speak to your needs without speaking over you. And the most powerful thing you could have in your corner is somebody to just bear witness. Even if they're not speaking, just knowing that somebody is there in the room bearing witness puts some of these doctors and professionals on their toes, realizing, oh, I have somebody else that can speak to the fact that I'm speaking to this patient in this way. Because in the moment, you are extremely vulnerable. A lot of people fail to realize just how scary it is to go to a doctor, to go to a medical professional and ask for things that affect not only your body, but your daily life. So just having somebody there that can bear witness to those things is incredibly powerful. And there are organizations dedicated to doing that. And there are some that are regional to you or in your community already doing that work.
Yeah, I like that. And I know a lot of us have probably had to do that for like our parents, for example. I've definitely had to do that for my mom in different situations. So then returning to the list of questions, how do you make room for Blackness in your disability and disability justice spaces?
I think there is a growing recognition within disability spaces that there's Blackness at the core of disability justice. There is, I think one of the hard parts about being Black and disabled is that there's not a real recognition of the completeness of Black disabled people in any one space. But we know for a fact that Black people were instrumental in the disability rights movement, and there were disabled people instrumental in the civil rights movement. And technically all of it is civil rights if we want to get technical. But we don't really recognize those things very well. We talk about, especially in Black spaces, the ways in which we overcame and that we were stronger than our diagnosis. We didn't let anything get in our way. But on the back end, you're realizing, oh, there were Black Panthers that were disabled. There were Black women in particular who were dealing with complex medical needs while on the front lines of the civil rights movement. There's Audre Lorde, who was the first person to really talk about self-care and understanding your boundaries and your new relationship to self as your body develops and ages or has diagnoses. And we talk about Black people in very strict terms that seek to, it's almost like a Marvel movie. Like we seek to see like very much of the strength of the person because that's what it took to survive. But we rarely ever see the vulnerability of that person. And we kind of, to a certain extent, deify people who were very human in the work that they were doing. And so when I try to make space for myself in Blackness and disability, I try to recognize that I am all these things at once. And it's not that I refuse to let people demand of me that I make them feel comfortable by my existence simply for being. Like I refuse to any longer quiet down the parts of myself to speak to Blackness or disability in any one circle. Yeah, and that's how I try to put it all together. Excuse me, I'm about to sneeze. Whew.
Yeah, thank you for that. Because we're whole people, right? We're not bits and pieces of ourselves, depending on where we are. So there was a good question about pain. So I'm going to trust this one. So Kayla Owens asked, I'm a clinical research coordinator that studies pain and comfort management in individuals with cerebral palsy. How do you see research aiding in the issue of adequate pain management as it applies to individuals with disabilities and more specifically Black individuals with disabilities?
Well, first, one of the things that I feel needs to be said, particularly for people who were diagnosed with disabilities as children, we don't really get treated for our disabilities past the age of 18 or 21 years old. Because a lot of the services that we get as disabled children are funded through our school districts. And so when you graduate or when you age out of the system and you're not in transition age services, or you are not continuing to go to physical therapy, you really don't have access to the services that aid in pain management or orthopedic interventions and things like that. What I really would hope, I think that, and especially with like long-term diagnoses that are seen as just physical, there's not a lot of recognition that we are in pain. Like I'm in pain all the time. It's like an echo in the back of my head. Like it's not at the forefront every single day. But I think there's a lot more recognition that there is a chronic pain element to a lot of these childhood disabilities that aren't really known for their pain elements. And I really don't know, because I really haven't been treated for my cerebral palsy since I was 18 years old. And when I look for services, I literally have to go to my doctor or my insurer and come up with new and exciting aspects to my cerebral palsy that need treatment in order to get treatment, like physical therapy and interventions. So that's really a barrier in my knowledge base around pain management as it applies to disabled folks. But yeah, and there's also like the implicit bias in medicine, or the very outspoken bias in medicine, where people think that Black people can tolerate more pain, or that because we're quiet about it means that we're not in actual pain. And in reality, we've been taught not to complain because we'll be criminalized for it or we'll be seen as drug seeking. So that's really a gap in my own knowledge, because I've tried to get treated for it. It's not really working out that well.
So a related question, and offer what you can. What do you think medical schools, nursing schools, schools of public health, et cetera, are missing about caring for people with disabilities and chronic illness?
What I fear that a lot of doctors and physicians and public health workers do not know is just how impactful what happens in a doctor's office or in an appointment is. I try to impress upon medical professionals that what stays in that doctor's office does not stay there for us. What you write down in our charts, what you say about us, what you say to other people about us, even your colleagues, that can impact the way that we literally live day to day. So for instance, if a doctor writes down that like I have intense or severe cerebral palsy, that means that I'm not allowed to go get a car or drive or get lessons to get a car to drive. And that means that I then have to take paratransit. And then paratransit means that I have to wait 4 to 5 hours just to get on the bus, let alone the pickup times that is another 4 to 5 hours to get dropped off back home. That means that I have to schedule my days completely differently around how I can get to the bank, to doctor's appointments, to go grocery shopping. And that one little note can have ripple effects on my day-to-day life. It could mean that I'm institutionalized in some cases. It could mean that people take away my ability to manage my own money, where I live, how I live, things like that. And I mean, when I say people and public health professionals have a very deep-rooted power in our lives, a lot of people think, well, that's not my purview. Like, I am here doing the work with one-on-one or with this group of people, and then whatever happens beyond that, that's not up to me. But the reality is that it very much so is. It very much so is your responsibility to take care and understand just how powerful you are. When we talk about all these large cases in the media around conservatorships and guardianships, where we talk about the troubled teen industry, where children are getting shipped off and abused in residential facilities, when we talk about all of those things, they start in a doctor's office. A lot of times they start in a doctor's office. So making sure you all take care to understand exactly what you're saying and how you're saying it is incredibly important.
Thank you for that. So we're going to shift gears just a little bit. So in your social media, I know that you've talked a lot about how the pandemic unveiled a lot for able-bodied folks, especially around access policy and disability. What do you feel like the pandemic was able to uncover for you?
Lord. That's a good question. It's, I really do appreciate that question, because usually the question I get is, what did you think about the accessibility that became available for everyone during the pandemic? And it's hard, because during the pandemic, while the accessibility was happening, disabled people were left to die. And I honestly thought with the pandemic, what revealed to me is, I thought people were more selfish. And they are, but it just in a way that doesn't actually benefit them, So when we think about the pandemic and people abdicating all responsibility to the disability community, because they don't want to wear masks or be inconvenienced or not take a vaccine if they are able to, I thought they would want to preserve themselves. I thought that they would want to not, like, from childhood, I've been told by non-disabled people that disability is worse than death. Disability is worse than death. And now you have a situation in which not only a million people have passed from COVID, but now 4 million people, an estimated 4 million people, are disabled from COVID. And now there's like this sense, like, people are all coming to the conclusion, oh, we really don't have the resources. All these things that we believed about disability, that disabled people were trying to tell us weren't true, are actually true. Like, everything that we believed about the system that is in place to care for disabled people, this system with a robust amount of resources, you could just tap into them easily and everything will be okay, that doesn't exist. And what it revealed to me is so many people are willing to throw disabled people off the ledge and forget that our ankles are tied together. And I tell people all the time is that I try to tell people that disability is life's fuck around and find out, not in the sense that disability is a punishment, but in the fact that every single thing that you've neglected while you were not disabled, or when you weren't thinking about it, or when you weren't looking at the system, and when you didn't need it, everything that existed before you got there is still going to be there. And if we do not build up the system before we need it, then it will not exist for you when you need it. And people are all now coming to this conclusion that, oh my God, we didn't prepare for this at all. Nobody prepared me for this. And disabled people are just kind of nodding along like, what do you want us to say? We've been trying to tell you all for years that we've been underfunded, that your rights are so tenuous now. And I think that scares people the most is with things like Eric Adams and his policy of rounding up mentally ill people, and all of these things apply to you. And ableism affects us whether we have a disability or not, because your ability is not promised. But now people are kind of in the find out stage of their own journey with disability, and it's terrifying them. And there's nowhere to go. You know, like that's the sad part. A lot of people love to say, we can move to Canada, we can move to New Zealand, we can move to Australia and Finland and all these great systems for medical care. They don't let you immigrate there if you have a disability. They don't let you go. Like Canada can talk all at once too about how it's a welcoming place, but they have been caught several times trying to deport chronically complex children because they're too much of a tax on burden on the system. So all these ideas around what you were able to do when you have a disability is really defined by the society that you live in, and people are coming to that conclusion.
Yeah, thank you for that. I know that I just give you a chance to drink some water or whatever. We were in a house search last year, and we really wanted to find a place where our parents could navigate a home easily. And so, you know, multiple mobility issues and disabilities within our sets of parents, and thinking about getting like a ranch style. It is almost impossible to find a ranch style house, especially in the Midwest and in Minneapolis, but it's just like they don't exist. And then the houses are so old that the staircases are narrow, and there's just like all these things that make houses inaccessible to folks with different mobility concerns, including myself and my husband, depending on which surgery we've had when. And so just thinking about the policies around housing that I hadn't even thought about.
Only about 5% of houses in the United States are ADA compliant. 5%, and we are looking at a rate of disability in the range of 26 to 27%, probably higher with the pandemic. But additionally, one of the things that I found, just like I'm a Zillow, I'm a huge Zillow fan. I like stuff I cannot afford. Like I'm excited. I get so excited. But one of the things that I found, so there's a house that I was looking at, not even like 30 miles from me, right? And it was a man that had created an entirely accessible apartment for himself. He made one of the bedrooms a bathroom that was like a walk-in shower, where he had seating and bars and all this stuff. What I have found is that even when a home is accessible, it doesn't sell. Even sometimes the aesthetic of disability is so much of a deterrent that people refuse to buy it. Now, people are doing more so because the housing market is so competitive right now that they'll just rip out that stuff. But I've seen apartments that are fully accessible, beautiful apartments that will not move. And there's like this implicit bias against anything disability related. People become belligerent when you start suggesting to them that they need to plan for a future in which they are disabled. Even just the idea and the idea of having a grab bar is so insulting to them. They will fight. Like I have friends that work in the hotel industry, and they say that sometimes if a hotel is fully booked and they assign a non-disabled person to a disabled room, they will get complaints because they're not disabled. We don't need that. They're insulted by the implication of safety because it has the aesthetic of disability. Yep.
I can't. So
yep.
Yeah. So yeah, we have 15 minutes before we jump into the audience questions, but there's a few more here.
Mm-hmm.
Are there advances in disability healthcare or tech that you have been excited about?
here's that. Oh, okay. I have such a complicated relationship with advances in technology, because here's my thing. One of the issues that I find is that we individualize accessibility, and that is most prevalent through how we address technology and how we use technology as disabled people. I'm glad for the accessibility on iPhones and smartphones, and the more prevalence of Zoom calls with ASL captioning. That's all really good things. And people always laugh at me because I always bring this up, but the wheelchairs that climb stairs are for one person, right? They're for one person that carries one person up a set of stairs. And it costs like $50,000, $60,000, $70,000 for that wheelchair. A ramp will cost a fraction of the cost and be accessible to everybody that traverses that ramp. Right. And so we have this very individualized model towards disability. We have a very medicalized model towards disability and how interventions are supposed to act in our lives. And what I'm most excited about is community around accessibility. And that could take form in tech and in some of the more brick and mortar ways in which we create accessibility. What I would hesitate people doing is over reliance on technology as it intervenes in our need for accessibility, because it often leaves people out. But we live in a very capitalist society that says that accessibility is for profit. I mean, that's literally how we operate. So am I excited that things are becoming more accessible, like gloves that interpret ASL, or that's cool to me. But I really want people to not miss the forest through the trees and try to really build a society that is in and of itself accessible, rather than relying on these individual models that leave so many people who cannot afford their own accessibility out.
Yeah, it's like you create another hurdle in the process.
Yeah.
Accessibility. So what do you think the next couple of years will look like for folks with chronic conditions? So we're moving perhaps a little bit past COVID, not clear on that yet, perhaps into another pandemic, unclear. But what do you think that looks like?
So one of the things that I think is going to happen, I think what I'll say is this: I want people to get their paperwork ready. I'm going to be very blunt about it. Whenever there's an influx of disabled people, whenever there's an issue with disabled people needing accommodations, state welfare systems, support systems, there is like this kind of purge of who actually needs accommodations, who actually needs services, who actually needs Social Security. So make sure you're getting your paperwork together. You can see the writing on the wall with that. So making sure that you have everything documented. If you had a positive COVID test and it's not on your medical record, make sure it's on your medical record. If you have diagnoses that you want to pursue, do it quickly. You need that. From what I'm hearing, you really need that. Particularly after this year, it's going to be much harder to get that documentation into your medical record. When it comes to chronic illnesses and disabilities, there has to be a greater investment societally into home and community-based services. What we saw during the pandemic, at least initially, is that a third of all deaths occurred in congregate care settings. We have been fighting for what is called home and community-based services, which is services that happen in your home, happen where you live, making sure that you don't have to leave the support system and community that you're in. But we've never fully funded it. We started dismantling the institutional system around the 70s, but we've never fully integrated disabled people into society. Our integration is fairly recent, let alone funded the supports needed for disabled people to live in the community. If we want to build a more equitable society, we're going to have to invest in those things. We're going to have to fight for those things. People have been fighting for them for decades. We need those things fully funded, especially with the large influx of people with long COVID. Additionally, what I fear too is that there is this resurgence of desiring to institutionalize disabled people. We see it with Eric Adams. We see it with Gavin Newsom in California with these care courts. And that is very frightening because it takes away so many of your rights, so many of your rights as citizens, your autonomy, your ability to manage money. And there are supports that are not as restrictive as some of these conservatorships and guardianships. For that, I would look to your state's protection advocacy agency to find out more if you're struggling with knowing what that is. But I feel like a lot of people are trying to institutionalize disabled people en masse again because they think it's cheaper. They think it's easier, and it really is not. Like, there's all the data shows that we're spending more money to institutionalize than it would cost for people to live in the community. And I'm not saying that the supports in the community need to be built out more, but if we continue to invest 5 times as much to institutionalize people as it would take for them to live in the community, you cannot continue to make the argument that it's cheaper and easier. You just can't. So where am I going with this? So what I would say is make sure that you have everything documented. Again, if you're a public health worker, if you're somebody in the public health sector, make sure you are very, very, very careful what you put in people's medical records. Extremely careful. Make sure you understand that even if you are a mandatory reporter, make sure you understand the implications of what you're doing before you do it. And when you institutionalize somebody, that is not just a blip, that is not just help. A lot of times these state-run inpatient psychiatric facilities can do more harm than good. So understand the risk you're taking with somebody's life. And I'm not saying that help isn't needed, but we need to be more robust about what we offer people in our communities before we decide to lock people away for being ill or different. And things are going to get scary. Things are going to get very scary. And we need to be on our P's and Q's.
Yeah, thank you for that. Really appreciate it. I know a lot of people became aware of conservatorships because of Britney Spears and everything that happened around that. But it's been really interesting watching the debate around, Kanye West and all of these other folks who are managing or not managing illness and disability. And so, yeah, I haven't even thought about what does that look like for Minnesota and keeping our loved ones safe over the next few years. Thank you for that.
Sure.
There's some really good questions in the chat, but I want to ask you for our students here, do you have any advice for navigating particularly grad and professional programs as a person with a disability or chronic condition?
Yeah, so what I went to grad school myself. I went to grad school abroad, which was a whole different thing. They had universal healthcare, so it was like a treat. But what I would suggest, if you're in school and you're in an educational setting, or even if you're working, first of all, you have to set up your boundaries first. You have to set up what you think is safe for you to disclose, what you feel is necessary to keep to yourself. I get asked by a lot of organizations to encourage people with invisible disabilities or encourage people with disabilities to be upfront about their disabilities and to make sure that they are being as open, as honest as possible. Like, we're a family here. And they don't like me because I'll tell them, like, there's a reason people are hiding it from you. There's a reason, there's cultural implications, there's societal implications. There is a very real history of penalizing people for their illnesses, their disabilities, and their need for accommodations. And so what you as individuals need to do is set up your own boundaries and stopping points as to how you want to talk about your disability, because no one who's not going to face the consequences of you being open with it should dictate how you talk about it. Especially if you are Black or brown. We know the history of disability in our community, as well as how we are criminalized and harmed for being open with it. So that's the first thing. The second thing is, I know this is counterintuitive to what I just said, but be as open as you can be as to what your needs and accommodations are, because otherwise what winds up happening is they'll blame it on poor performance or like your unwillingness to be a part of the classroom, and you really just need accommodations. So be as upfront about what you need. You don't always have to be as open. You can have, like I said, an advocate with you, talk to your disability aid office, see what can be done discreetly if that's what you want. Also make sure that you allot time to just rest. Yeah, I know you want the good grade. I know you want to be the top of your class, but C's get degrees. And sleep, you will never get sleep back. So take that rest, take that nap, take the time to rest and understand your body and where you're setting boundaries. And it all comes back to like Audre Lorde's definition of what self-care is. It's not a bubble bath. It's not, painting your nails. It is really just understanding your relationship to self and understanding where you need a break and to take time to yourself and to really kind of reorient how you need to interact with the world for your own care. And you need to do that on a repeated and continued basis for the rest of your life. And it's not going to be the same forever because your body's going to change, your mind's going to change, things are going to be different, but constantly being aware to know yourself and to question what you need.
Thank you so much. I hope that our students got something from that. I know that I did, and I'm also a student, so I'm constantly navigating fatigue, pain. We're trying to drive through snow to get to class. I'm like, no, I don't like. And then being in the classroom in a pandemic. Let's talk about that.
That's a lot. No, I refuse to go to school anywhere where like snow is too big of an issue. Like I went to school in Pennsylvania, so it was one, but I was always like, I'm not walking there. You're driving me. Like they would have a van come pick me up. I'm like, I'm not doing it. So yeah.
Yeah. Why didn't I think of that?
I'm just saying.
Yeah, we'll see how long I can take it. But yeah, there's a couple of really good questions in the chat and keep sending those. So I wanted to go back up to Claire. Could you talk a bit about the intersections of anti-fat bias, race, and ableism? I know it's a huge question, it is, but I'm thinking about how anti-fat bias fits into this conversation, especially about everyday assumptions healthcare practitioners have about fat people. Thank you.
Yes, so I personally, for me, like I try not to like tell people how to think about these things, but personally for me, almost every single marginalization leads to disability in some way. In every single marginalization, you find that fat people in particular are not, they're not seen as reliable narrators of their own health, which is very similar to how disabled people are not seen as reliable narrators, because their body is supposedly speaking for them. And I think that people see fatness as choosing disability, because they see fatness as a choice of poor decisions and rather than body chemistry, environmental factors, things like that. And it's an easy out for a lot of physicians to just say, oh, you're fat, you need to lose weight. I mean, like, I remember one time so I don't know if you know this, but if you travel from the East Coast to the West Coast and then back again, there's like certain bacteria on the West Coast that like people from the East Coast cannot easily like integrate with. So I came back from California after a summer with walking pneumonia, and because I had like this respiratory infection, and I went to the doctors, and everybody in my family was like, oh my God, it's heart failure. Oh my God, like it's this, she's like, she just needs to lose weight. There's all these issues with her weight. Like it's probably all to do with that. And the doctor's like, well, this cough will probably go away. We'll have to do like heart scans. All they had to do was listen to my lungs. I had fluid on my lungs. I was walking with pneumonia for like 3 months. And I was like 14 or 15 at the time. So I was fat, but I wasn't like big as I am right now. And they so easily wanted to like brush it off and be like, oh, that's just as a result of her poor health decisions. And when it comes to fat bias, it's so similar to ableism, because again, they're seeing that you're choosing to take yourself out of the equation, that you're choosing your health issues. And when it comes to race, again, you have bodies that are designed thicker, like not necessarily, and how do I put this? Trying not to be problematic, but like you have Black bodies are generally seen as thicker. Like we have a culture that is very much Americanized to herald thinness now, but historically we've been thicker women, we've been rounder, we've had heavier features. Like that's just how we are. And it's no mistake that doctors will look at a fat body, a Black body, and think that it is our personal decisions leading us to poor health. I don't know if that answers your question, but I think there's a heavy intersection between race, ableism, and fat bias that is all designed to lead people to disability and then eventually to death.
Yeah, thank you for that. I know we had a speaker like 2 years ago, a different series, but we talked about anti-fat bias and how it's rooted in anti-Blackness because of the reason that you mentioned, because Black women are generally built in a different shape anyway, and have more body fat and muscle a lot of times. And folks not wanting to be associated with Blackness or Black women. And so you can even talk about misogynoir and wanting to be closer to that thin white ideal, which is then associated with holiness and rightness. And so we haven't even touched on the religion part of that, and how folks associate fatness with sin and disability with judgment of something that you did. So
yeah, exactly.
Yeah. See what else is in the chat. Y'all have been talking. I don't know what this means, but it says, Imani, you make so many good points in obtaining and maintaining CADI waivers that keep people in the community are difficult to navigate.
Yeah. So basically, I assume that it's like your version of like intellectual and developmental disability waivers for disabled people to live in the community. And they're very difficult to navigate. Like some people don't even know they exist. Basically, they're basically like permits to live in the community while maintaining access to services as a disabled person, especially if they are somebody that is considered on the intellectual or developmental disability side of the disability community. And they're very difficult to navigate. I remember I did a chart of one in my state, and there were like 15 of them. And they had so many caveats and like requirements you had to meet. It's very difficult to keep disabled people in the community. They're right, yeah.
Yeah, so let's see. Can you share your perspective on person first versus identity first language? Good question.
Sure. So I want to give a little bit of background first. I personally go with identity first language, which is disabled person. Person first language would be person with a disability. I personally was very hardcore identity first language. Like, I'm just a disabled person. You will address me as such, because let's be clear, I'm not uncomfortable by my disability. You're uncomfortable with my disability, and you're the one having to create all these like weird phrases around disability in order to address me. But then when you actually look at the history of identity first language or person first language, person with a disability, it's deeply rooted in the disability rights movement of the 50s, 60s, and 70s. And there was a lot of institutionalization and moving disabled people about without their permission, without their consent, just treating disabled people kind of like movable objects that you can like push out of your way and keep on the periphery of society. And so when disability advocates started protesting en masse, their rallying cry was, I am a person first. I am a person. I'm a person. I'm a person with a disability. And so there's a lot of older disabled people and people who people who work in professional settings around disability that use person first language. And if you work in public health, it should be noted that when you do any sort of like grant funding or paperwork or trying to get investors engaged in disability discourse, they will actually a lot of times require you to use person first language, even if you are somebody with a disability that says, I am a disabled person. And it was very difficult because I was working for a disability organization and I was helping apply for grants. And I was like, why do you keep using person first language? They're like, they'll literally throw out our application for funding if they do not have the language that they prefer. And a lot of times it's reinforced by non-disabled people rather than listening to the younger disability community that is more heavily identity first. But that's a little bit of like where we are kind of right now with the discourse around it. I personally ask people what they prefer, person with a disability or a disabled person, and I take their own cues because it really is individual to the person. And there's so many different factors as to how people would identify with either one.
So we have a question from Anonymous. I am the only visibly disabled person in the room and find myself having to be the one pointing out access issues. I am also white, so I recognize I have privilege in the space. How can I advocate while also making sure we don't overlook Black and Brown perspectives to the disability experience?
What I would say is I think there's safety in numbers. I also think that we need to be in constant conversation with one another. So making sure that you are meeting with people with diverse disabilities and diverse racial, gender, and backgrounds regarding sexuality as well. Just making sure that there's a lot of diverse perspectives on what accessibility means to them, and making sure that you are the most robust advocate possible in those moments, and understanding where people want to speak up for themselves and where you can stand back, or when you want to when people want you to take the lead and be the face of those accessibility requests. I think that's the best way to do it. Again, you have to be in community with people in order to have these conversations and to really build a sense of trust with your own community. And I think that that's the best way to go about it, is to continually have that conversation with other people.
So I have to scroll back up for a question from Sarah Hurley. This is regarding the pandemic. So she says, thanks for being here and I love your TikTok. My question is related to work culture, as non-disabled people feel done with the pandemic and want their version of normalcy, which never worked for disabled people. We've gone from a culture trying to adapt to massive change in how we work in 2020, increasingly back to accommodations-based work alterations, maybe with a bit more flexibility. Mm-hmm. There are likely managers and leaders in this audience. What message do you have for them about work culture, and how we create a space where disabled people are not always asking for the things we need?
So with work culture, I feel like there's, like you said, there are a lot of people that are trying to get back to normal. And to be quite honest, I see a lot of non-disabled people who use productivity and work culture as a way of keeping themselves out of disabled spaces or keeping disabled people away from the spaces that they want to be a part of. And work is especially famous for that, right? But I would also force people to recognize that your hustle culture, your grind culture is disabling you. It just is. Like you're grinding yourself to nothing. Like nothing that comes away from being grinded up, it comes out of it whole. And with the pandemic, your accessibility benefited everyone. Like, what culture are you really missing out on by not being in the office? And particularly for Black and Brown people who enjoy work from home. We enjoyed work from home for a completely different reason than white people did. Let's be honest. Like, we didn't have to deal with the microaggressions as much. Like, we were in our own home, we were in our element. We felt better about being in those spaces. I think what people need to recognize is that the future of work is remote. The future of work is promoting a work-life balance with staff and people. And this idea that you're never going to get normal back. there are people missing from your dinner table. There are people missing from society. And this idea that we have that we can just get normal back and just push people to the margins who have been disabled, and forget the memories of the very people that died, that's never going to work out. Like, there's going to be a breaking point. And so recognizing that your staff are not mules, that your staff have lives that they want to live, and being transparent about the demands of the job, that is the way forward. That's the kindest way forward. And a lot of disabled people do not disclose their disability because they know that you don't want them there. That's why. That's why people are so secretive with it. So I would encourage managers and staff to really recognize what you're sacrificing by being in the office, what part of your lives you will never get back, and move forward with the recognition that accessibility can serve all of us.
Samantha asks, I am currently an MSW student, so a Master of Social Work, and was wondering if you have any recommendations for how social workers can help advocate for people with disabilities.
So the very first thing I would do is make sure you take stock of the way you communicate. So like, make sure that you have either access to ASL translators or captions for Zoom meetings, making sure you have devices where you are, like, make sure you have a plan for how to communicate with people for whom communication is difficult. That's the first thing. The second thing is to never assume capacity. People always assume that disabled people have a lack of capacity to direct our own lives, and people will operate with us under that assumption. But the reality is that anybody is capable of good, harm, great things, doing bad things. We're all just people. And so recognizing that you have your own bias, and giving yourself a second chance to really kind of interact with people that is outside of that bias, because our first initial thoughts are always going to be our first initial thoughts, right? It is our second, third, and fourth thoughts that we can control. So making sure that you are fighting against that bias when you interact with disabled people, and making sure that you are really addressing it and taking people at their word, and allowing disabled people to be reliable narrators of their stories as it pertains to how they interact with you. I would also suggest reading work from disabled people, particularly disabled people, diverse groups of disabled people. So like the Disability Visibility Project, it's a good place to start. The Rooted in Rights blog project is also good. They also show us perspectives on just multiply marginalized identities and how they interact with one another, and how you could show up for those communities. I think that is the best way, is to always refer back to disabled people and how we want to tell our own stories.
Hard agree. Always centering the marginalized. I'm going to make this the last question, Imani. So it says, Libby says, when do you recommend outing yourself during a job process? I want to find a place that fully accepts and celebrates my disability status without being discriminated against. Thank you, Libby.
Can you repeat that question? I'm sorry. I think I lost it in the chat.
Oh, so I lost it, but it says, when do you recommend outing yourself in the job application process, basically?
So here's what I recommend. So when you're applying for a job, they'll often ask you in the application process, what like disability do you have? Do you identify as a disabled person? What I would recommend is, that's up to you whether or not to disclose. I personally click don't disclose. Do not lie though. If the option is I have a disability, I don't have a disability, I choose not to disclose, just put I do not choose to disclose, okay? Make sure you're doing that, like, okay? Additionally, what I would do is, once you get to the, like, if you have a visible disability, there's no way of like actively hiding it during the interview process. You're gonna have to do what you have to do. But I would choose to disclose once you sign your contract. Okay, choose to disclose once you sign that contract. Make sure that you are as upfront as possible. Sign it, then disclose. always make sure you also have a paper trail. That is incredibly important. Make sure you have everything in writing. HR will be like, well, let's come into my office and let's discuss it. If that happens after the meeting, you need to write up a summary and email it to the HR director. Be like, thank you for discussing A, B, and C with me. Make sure you are constantly having a paper trail. Like, I cannot stress that enough. Now, always BCC your personal email, because if anything goes off, you want to have that record, okay? So making sure you're doing that at all times. And then, you know, being as upfront as possible, like, but will also recognize your own boundaries is important. Yeah, that's what I recommend to do it. And I feel like that works the best for most people, because it's not, you're not lying, you're not getting yourself, perjuring yourself on a like official government document with the EEOC disclosure. But you are also being as open and honest as you can about your diagnosis as soon as possible.
Super helpful. We are at 11:01, and so being respectful of each other's time, we're going to end there. But I do want to thank you, Imani, for your immense wisdom and for sharing with us for the last hour. Thank you all for attending. If you can fill out the evaluation, that would be very helpful to us. And Imani, if people want to reach you, how can they do that?
You can find me on Twitter. You can also find me on Mastodon, I guess. You can also I'm also on TikTok and Instagram. So you can find me on all the platforms. I'm Crutches and Spice, and I should be like the first one that comes up.
All right. With that, we thank you all and have a wonderful and warm day. Take care.
You too. Thank you.
Bye.